So very good afternoon, and I'm quite surprised to see people coming in. I don't know pre or post lunch, whatever it is, but it's a very pleasant sight. So she has covered, Shalini has covered basically all the baseline things. It's 12 minutes, bache. It's 12. Yeah, we got to guide them. So she has basically covered the cataract and glaucoma combined, the basic challenges. So from that I'll come actually. Cataract surgery actually, glaucoma surgery and cataract surgery combined have multiple variables. So important is conjunctiva is available or not available, glaucoma is primary or secondary, if it's secondary what is the cause, and then what are the IOP levels, are they very high, they are moderate, this thing, and what is the age of the patient, because we don't know for how long we have to manage the patient, for how long, this thing. So if the conjunctiva is available, no big deal. Shalini has dealt with everything that is required, but now we are dealing with another situation. Now conjunctiva is not available. Now what can we do? So we can do a GDD, or the other option is that we can do MIGS or CPC. So there are two different spectrums altogether. One comes for the glaucoma when the pressures are not very high, and one comes when the pressures are high and you have other risk factors. So when to do a valve with cataract surgery? So basic fundamental is that in trabeculectomy we require conjunctiva where the valve can form, and second is we need to have a nice healthy anterior segment where the ostium can be made and it will remain open. So secondary glaucomas are often where the ostiums tend to close. And the third thing is when we cannot really use MMC because of primary collagen disorders like high myopes and all that, and other disorders. Therefore, in them, if the pressures are very high, GDD makes a very good option. So, lots of questions. People have this, that why will a GDD work when TRAB is not working? And in what way will GDD be a better option? So, if we look at these two blebs, the TRAB bleb is located right at the limbus and it's a thinner bleb, conjunctival bleb. Other bleb is a thick bleb and it's far away, so it's a safer eyeball. The other bleb is thicker, this is thinner, and the area is also, in the valve, the area is much bigger. So if the IOPs have been high, to a significant level, it will control pretty well. And also they're relatively immune for blockade by iris, blood, or if the blood aqueous barrier is slightly leaky, they are affected lesser than the TRAB blebs are affected. So we see these examples of scarred conjunctiva, whether we have conjunctival diseases like Stevens-Johnson or advanced VKC, chemical injuries, multiple surgeries, or we have something like these war injuries where you have lots of these splinters and the conjunctiva is really awful. Pseudophakics, they really make poor patients for trabeculectomies, especially after SICS. You see this one patient who came to me for a PK, following us, this old patient came for PK, but actually the patient had very high IOPs, the valve was done and the patient was able to see. Similarly, like neovascular glaucoma, secondary glaucoma, so in this the ostium will close because of either blood or fibrin, or it will grow inside the ostium. So therefore, it's a good choice for a valve and not for trabeculectomy. Traumatic glaucomas and cataracts are often combined. And in them, actually, it's a real good choice because angle recession glaucomas are mostly difficult glaucomas to treat by a TRAB. You do a very good TRAB is fine, but otherwise this is a good choice again. Then PK-related glaucomas. Most of the patients following PK will develop cataract because of loads and loads of steroids are pumped in the eyes. And then they also may be steroid responders. So in PK, I tell everybody, don't be a hero, don't do valve and the cataract together. Here, do staged. And you can do it before or after depending upon the situation. If the IOP is pretty high, good to do a valve first and let it go and then do a cataract later. Same for refractory. So Sushmita is covering pediatrics, so I'll let go pediatric. And uveitic glaucomas are almost similar like NVGs, but in this you have very high peaks, so therefore IOP loss, so therefore the disc loss could be quite a bit and we can't even see the fundus, so that's where it helps a lot. Preoperative preparation, I think Shalini has dealt with. All I would say is here we are going to have usually inflamed eyes. Ocular surface will not be good. So control the inflammation of ocular surface, intraocular inflammation, if there is any systemic disease, and usually when you resort to a valve, pressures are pretty high. So menthol is a good option to give before surgery. Now how do we stage? Before cataract surgery, if the IOP is very high, glaucoma is pretty advanced and cataract is minimal, it's good to go for a valve first and cataract surgery later. If with cataract surgery, if this moderate glaucoma and other risk factors are there, like you have a uveitic glaucoma or a traumatic glaucoma, then it's good to go combined. And after cataract surgery, if IOP is not a big challenge, it's good to do just a cataract first and manage with medication. If they fail and you can't do a trabeculectomy, then go for a valve. So this is a video of a combined surgery. This is a patient of uveitic glaucoma. She is 35-year-old lady with intermediate uveitis, zipped up angle and very high IOPs. So here we'll be doing a Ahmed valve. So we make a deep pocket. The pocket has to be really deep and between the two muscles, lateral and medial rectus. And then I do this tunnel technique in which, now this is the valve is being primed. It's important to prime Ahmed valve because sometimes it takes a lot of opening pressure. It's different from the non-valve devices. And now we put this inside in the pocket. We make sure that at least it is 9 to 10 millimeters behind the limbus and not anteriorly, because whenever you keep the valve anterior, be prepared, it will move forward and the plate will get exposed. So here is a tunnel. It doesn't require any additional instruments. We make one small cut here, 7 millimeters behind the limbus. This keeps your thing also that you're not really too far or behind, and that plate is 10 millimeters behind. This is at the limbus, and nothing, using a simple crescent, we make a small tunnel in which the tube will fit very well, and tube will also be covered and there will be no sutures. So therefore we are avoiding the need for sutures also. And this at the limbus, why one doesn't go right in is because from here we can change the direction of tube. If we use only a needle, then changing the direction in the anterior chamber becomes difficult. So now we'll fix the valve. Valve is fixed always with non-absorbable sutures like a Prolene or a nylon. It's never with Vicryl. Just remember, it is an 8-O suture and it should be tightly fixed because we don't want the anterior or the posterior migration of the valve. And both the eyes should be tightly fitted. There are multiple kind of sutures you can take, box sutures, this suture, that suture. The bottom line is the valve should not shake, because when the valve is slightly shaky, also sutures are loose, then there is a more chance of having hypertensive phase. So here now through this tunnel we pull this out. Just look at we are not having a straight vertical down the tube. We are just giving it a 1 millimeter turn, because a vertical thing always leads to tube erosion. So now we pull it back and now we enter here for the phaco. So standard temporal phaco, nothing really great about this phaco. I think it should go quickly. Yep. Usually uveitic cataracts are pretty soft cataracts. They don't really have nucleus. They just have one blob of opaque material. And then in uveitic cataracts, do not ever put a hydrophilic lens. Put a hydrophobic lens. If patient is poor, put a PMMA lens, because hydrophilic lens attracts a lot of inflammation. So once the lens is put inside, now here we don't evacuate the HPMC. We cut the tube of the desired length. And now we make a track inside the anterior chamber. So now here we make sure this track is parallel to the iris and not otherwise, so that it is as far away from the cornea as much as possible. Now through this we are going to insert this tube. This is 2011 video, so those days we were inserting in the anterior chamber. After that, most of us in a pseudophakic patient are now putting in the posterior chamber actually, and not in the anterior chamber. And then we fix the tube. We don't suture. The tunnel is not required, because tunnel is only a cover for the tube. It doesn't have any other purpose. So now we're going to fix the tube and close the conjunctiva. Conjunctival closure has to be as meticulous as it is for trabeculectomy. But here it's not a conjunctiva alone, it's a conjunctiva and tenon both. So both should be taken together, and not only the conjunctiva, because on the tube we need as much tissue as it is possible to be up there. So post-op, this is the post-op. It really did well because it was mostly posterior uveitis except for the glaucoma part of it. And quite a while later, this is the way it was. It was a really bad case, and it's been, I think, 13 years now. The patient is doing pretty well. I was worried about the corneal endothelial decomposition. Somehow it's not happened. So complications, the worst possible complication is hypotony and shallow AC. So this we can avoid by a tight tube fit. That is the code word. And we never leave the AC soft. We make it hard. And in case there is slight challenge also, we can leave some amount of heron inside. The second is the tube migration in patients like this. So in this, this is the patient who's got a collagen vascular disease actually. So trap could not be done in this patient. In this, even the sclera melted. The donor sclera also melted. So really one has to think twice whether valve is the option in them or not. Tube erosion is a very bad complication because this is a ticking time bomb for endophthalmitis. So no matter how we do it, we do... 2 more minutes, yeah. It's 1 minute generally, no? So tube has to be covered, whether it's a flap, it's a sclera, it's a tunnel, it's whatsoever it may be, but it should be nicely covered to the extent that we have something nice sweet like this. So tube exposure has to be kept in mind. Initial phase is usually exposure, it heals, but later phase it does not heal, so let's not be in the paradise that it will heal automatically. Nothing will happen to her, we have to address it. Tube blockage like this can happen sometimes. So on the up here like that, if you use a 532 laser, it pulls out if it's a very fresh thing. But if it's not so fresh or it's more, then we can do a YAG with a lens. Tube cornea touch is to be avoided. If it is there, it is to be redone again. The tube has to be pulled out. An extender stroke a change of valve. Then tube retraction or long tube. Never consider a tube retracted unless and until you've done a gonioscopy, because many times an open tube sits in the angle and we are not able to see because of the corneal peripheral corneal opacities. This is that I talked about the tube exposure and all that. So take home is GDDs are very good devices, saviors in the face of odds. Cataract surgery can be combined before or after and used judiciously only on need, just not for a fashion or not for, I wouldn't use a word, not a nice word. Thanks. Thank you so much.